Hello, and welcome to today's webinar, Navigating Care Coordination with Confidence. My name is Marvell Adams Jr., and I serve as the CEO of Caregiver Action Network. I'm honored to continue the vital work of the Families, Addiction, and Mental Health Network with a particular focus on education. As many of you know, Caregiver Action Network, or CAN for short, is the nation's leading family caregiver organization. CAN works to improve the quality of life for tens of millions of family caregivers across this country, and as a part of our work, we remain committed to addressing key barriers caregivers face. In today's conversation, we'll explore care coordination, something that as caregivers, you are especially familiar with. In fact, in a poll that we shared in the lead up to this webinar, all registrants polled expressed challenges navigating care, particularly with battling prior authorization requests and access to healthcare services. So in today's conversation, you will hear from Tyler Scheid, lead policy analyst at the American Medical Association, who will shed light on the impact prior authorization has on patient care. And you will also hear from two individuals with firsthand experience navigating the healthcare system. Don Shedrick, a caregiver, social worker, and lifelong patient advocate, and Dr. Douglas Constant, pain management physician. What is care coordination? As CEO of Caregiver Action Network, we have helped constituents, caregivers navigate care, but also in spending 20 years as a senior living and nursing home leader. I have firsthand experience in not only just helping care recipients, caregivers navigate the healthcare system, but also navigating their path to home. And there are many aspects of care coordination that are, woven throughout all of that. So getting the right medication at the right time is really an essential part for both patients and caregivers to effectively and seamlessly manage their health. Many patients and caregivers face challenges in filling prescriptions, often due to cost, complex insurance rules, or supply issues. These challenges are not only exacerbated by social determinants of health like income, location, and health literacy. These create barriers to access and then increase disparities. Understanding how the medication access process works can help you get the coordinated care you deserve. During this webinar today, we will cover 6 main touch points that play a key role in treatment access so you can better advocate for your needs and find solutions that work. Let's begin with prescribers. Prescribers, like doctors and nurse practitioners, work to choose the best therapy for their patients, but growing bureaucracy is leading physicians to navigate more insurance rules and paperwork. In fact, 94% of doctors say that prior authorization delays necessary care for patients. So, in preventing those delays, it's really critical for providers to stay informed about insurance requirements and formulary changes and making sure to advocate for their patients if medications are denied. Meanwhile, health systems like hospitals or clinics work with pharmacy and therapeutics committees to decide which medications are available through their formularies. They can help improve medication access by streamlining approvals and coordinating care between doctors, pharmacies, and patients. Of course, this ensures that if a physician prescribes a new medication, treatment is available and covered on the formulary. So, acting as a middleman or middle person between pharmacies, insurers, and drug companies is the pharmacy management benefit manager, or PBM. PBMs negotiate drug prices and manage which ones are covered by health insurers. However, as already evidenced, coverage requires a lot of coordination in tandem with key players, making it challenging to bring a new treatment to the market at an affordable price, quite frankly. So then there's the health plan player, better known as the insurance company or Medicare, deciding which drugs are covered and what patients pay out of pocket. If you feel like coverage has become more restrictive, you would be right. Medicare plans now cover just over half the FDA approved drugs, and half of those covered drugs require prior authorization. So insurance companies have a major role to play. Simplifying their approval processes and expanding coverage for important medications, it can make access easier. We know pharmacies are our source for understanding medications, filling prescriptions, and getting them in hand. But pharmacies can also be allies in helping patients find lower cost alternatives to medications and connecting them with financial assistance programs. Most importantly, out of all this, and at the center of it all, is the patient. About 1 in 3 Americans do not fill their prescriptions because of cost. 33% of Americans not filling their prescriptions because of cost. And so this process can often feel out of control for the patient, and or their caregiver. But there are ways that, we can advocate for you and for your loved one. Work with your provider. If you're navigating prior authorization, work with your doctor to provide detailed medical justification when submitting a prior authorization request. Incomplete or vague forms are easy excuse for insurers to deny. Know your rights and explore assistance programs. Many states require insurers to respond to prior authorization requests within a specific time, especially for urgent care. Additionally, learning more about patient assistance programs, copay cards, or pharmacy discount programs can further expand options. Understand your insurance as well, so know what your plan actually covers. Every insurer has its own rules about timelines and what's considered medically necessary. It's confusing, but knowledge really is the power in this case. Better coordination among all of these stakeholders will ultimately make medication access simpler for everyone, especially for the patients and the caregivers who need it most. And if you're facing trouble getting your medication, feel empowered to own your access experience. And there may be options you haven't explored yet. And with that, I'd like to welcome Dawn, who will be sharing about her firsthand experience as a caregiver navigating care coordination. So Dawn, I can't help but recognize you are a wealth of knowledge when it comes to this topic of care coordination, whether in your personal life or your professional work. You have experienced this quite a bit. So, you know, I want to start there and just understanding, as a caregiver, but also, having been personally as a patient, can you talk a little bit about your own personal experience with navigating care coordination?
As you know, my mother is living with a progressive form of multiple sclerosis. She traces the subtlest symptoms back to the late 60s. I was
Wow.
born in 1974, so that's, been throughout my lifetime. And it's been a progressive, with some pit stops along the way, but it's been a progressive journey. And she has not been able to walk since 2004. But in the last 2 years, well, since 2022, there has been a significant progression
Mm,
of the MS. She needs additional care. She needed, it got to a point where we knew she needed additional home care support. I also, needed additional home care support. And the process of coordinating and connecting all of
mhm,
the dots and connecting all of the players has been incredibly stressful. The significance of care coordination is the communication, right? The connection,
mhm,
communications with all of with all the players, right? And I understand because of the way our system has evolved that
mhm.
particularly doctors, physicians, specialists are not waiting around to make a phone call and have a conversation, with a
Right.
primary care provider. But the lack thereof then puts a burden on either the patient or the family because that connection and communication is so necessary. Sometimes accessing test results. Most of my mother's providers are within the same medical system, like hospital system,
Mhm.
so they can easily access records, right? So if our primary doctor is waiting for results that the neurologist ordered, but
Mhm.
they don't see them in the system. Instead of my primary care physician, you know, contacting the office, sending a message or whatever, they're like, well, can you
Right.
contact them and ask them what's going on with the results? So then that's a phone call that I have to make, and then,
Yeah.
right? So it takes a lot of time,
Mhm.
takes a lot of
Mhm.
time, especially out of my work day. And sometimes I can literally, no exaggeration, be back and forth on the phone for like 3, 4 hours. I'm grateful that I had that training. My very first professional experience was in case management care coordination. It's like the bedrock of my professional practice, even though I don't
Mhm.
do that per se anymore. So again, I have the experience, I have the skill, but it just always reminds me and reinforces me, for me, the significance of being able to make sure everyone is connected in the most appropriate way.
Yeah, I mean, the complexity of what you are describing and what you're navigating, and the fact that it's not unique. to you. These are millions of other caregivers across this country that every day are experiencing exactly what you're saying. When you think about your professional experience as a social worker, you're helping someone on the professional side, but you're also seeing, that care coordination and the impact it can have. And so, could you talk a little bit about the impact that care coordination, or lack thereof, can have on communities that you've served?
Absolutely. I'll tell you that as I as I as I get older, I'm 51 years old, and I've been my mother's, caregiver since I was 22, in this capacity, right?
Mhm,
And
mhm,
so for many years, many of my peers, many of my colleagues, many of them were not, necessarily caregivers. The older that I get, so many more now, you know, of my
mhm.
peers, parents are aging, other family members, are chronically ill or disabled, or more than one of those, colleagues as well. And so I do have these conversations pretty frequently because a lot of folks know that I'm a long-term caregiver and that, just
Mhm.
professionally, I speak out more. I, offer trainings myself for the professionals that work with the caregivers, right?
Right.
And so it's interesting because now it's in those conversations that I literally see like the aha moments for folks. First, they get validated because they're like, they don't have the experience that I do of making all the calls, right? They don't have the experience
Mhm.
that I do working within the system. Not that I'm an expert, but I have the experience. And
Right,
so I find
exactly.
myself literally, including this morning, texting with folks, either them directly, like, Dawn, how do I access this? Who do I need to talk to about this? Or connecting, them with the appropriate resource, in the community, sending a website, sending a resource, or just giving support and space for folks to say, like, this is too much, you know?
The frustration that can mount for the caregiver, for the individual that they're supporting, and then we kind of turn around and wonder, well, why'd they miss the appointment, or
Mhm,
why did the medication not get filled? And it's like, well, these are all other layers beyond what we're even talking about. You're just trying to coordinate the care that's already taken place or that's going to take place. We haven't even
mhm,
gotten into all of the outputs that come around the medication that needs to be picked up and given, the doctor appointment follow-ups that have to take place, and then the cycle starts again. So this
mhm,
isn't like a one and done thing. We're talking about episodic care coordination that just, it cycles, on and off, and sometimes it doesn't
mhm,
have an off switch, where every day there is another thing of having to coordinate it. And I can just hear from the progression you've talked with your mom that is not only episodic, it can grow in complexity, over time,
mhm, absolutely.
as her condition changes. So, you've given us perspectives that really have been helpful, I think, for individuals that are caregivers, individuals that may themselves me receiving services and trying to figure out their own care coordination. But can you leave us, with some tips on how folks can navigate their own care journeys for themselves or for their loved ones, and kind of give a sense of these are some of the things you should at least focus on when you're trying to get out of that overwhelmed feeling.
Absolutely. There are a few things that I almost always share with folks or encourage, folks who I have the privilege to connect with, even if it's just like a personal connection, right? The first thing I ask is for their care recipients, medical providers, ask them if they have a social worker, especially if it's a provider who's affiliated with a hospital. Is there a social worker who can support me? Some medical
Yeah.
practices, I'm hearing more now, even privately owned medical practices, it may be a part-time social worker or nurse care coordinator. But I tell folks, start with the medical providers. If someone's caring for someone who's aging, I let them know. Every state has like an area on aging, right? Most counties in the
Hmm.
United States have, like in my county in New York, it's called the Office of the Aging, some sort of,
Hmm.
government, organization that supports the, folks who are aging. reach out to them, look up County Office of the Aging, look them up.
Mm-hmm.
The other thing that has been very helpful, just, with me, with my mom, is if your care recipient is living with a particular disorder, a particular chronic illness or disease, or whatever's the basis of their disability. So, for instance, my mother's living with multiple sclerosis. In the
Mm-hmm.
beginning of this caregiving journey, I eventually reached out to the National Multiple Sclerosis Society. At that time, they offered free respite. I don't even know what respite was at the time, but they offered
Right.
free respite. They had volunteers and donors who would offer specific support for very specific needs. Find out if there's an organization near you in your state, in your county, that specifically supports that, and start there, because they also, whatever they can't do, they can also refer you. Or we might not be able to offer respite, but we know that this organization does. We might not offer case management or care coordination, but we know, that this organization does, to at least like get things started, right? So as much as we know that there isn't a solid or really an infrastructure for the coordination, there
Mm-hmm.
are organizations, professionals, volunteers that I'm sure are nearby that if they can't, provide direct support, can hopefully, and most often point folks in the right direction. Yeah.
Don, thank you so much. This has been totally enlightening, and this is coming from so. I've been 20 years in working in with older adults and caregivers, 20 plus years. I think I'm getting more close to 20 than I was, closer to
How
30 than
long
I
have you
am
been saying
20.
20 years, right?
Yeah, like I'm pretty soon I have to upgrade that number, but thank you so much. It's been enlightening for me, and I'm sure for everyone that's tuning in. Now, to further explore the role prior authorization plays in healthcare access, I'd like to welcome Tyler Scheid, lead policy analyst for the American Medical Association.
Hello, everyone. My name is Tyler Scheid, and I'm a lead policy analyst within the Administrative Simplification Initiatives Division of the AMA's Advocacy Department. It's an honor to be speaking with you today, and I'm very excited to discuss the impact of prior authorization on patients, physicians, and caregivers. I'm going to start by highlighting the negative impact prior authorization has on care delivery using data from the AMA's 2024 Prior Authorization Physician Survey, and then I'll discuss some of the AMA's reform initiatives related to prior authorization, and I'll finish up by highlighting some of the AMA's prior auth advocacy resources. But first, what is prior authorization? Prior authorization, commonly referred to as PA, is a health plan cost control process that requires healthcare professionals to obtain advance approval from the insurer before a prescription medication or medical service qualifies for payment and can be delivered to the patient. Historically, insurers have often touted PA as a patient safety mechanism, but in recent years, insurers' messaging surrounding PA has shifted more towards the cost-saving benefits of PA. While health plans contend PA programs are necessary to control costs, physicians and other providers find these programs to be time-consuming barriers to the delivery of necessary treatment that actually increase costs both in the long and short term. Many of you may be familiar with the AMA's PA Physician Survey, as we have fielded it annually since 2016. But for those of you who aren't familiar, this is a national survey we conduct to assess the impact that the PA process has on physicians, patients, employers, and the healthcare system as a whole. We survey 1,000 physicians, including 400 primary care and 600 specialists, and our respondents come from a wide range of specialties and practice settings. We screen every respondent to ensure they are currently practicing in the United States, provide 20 or more hours of patient care each week, and complete medical services PAs, prescription medication PAs, or both during a typical week of practice. So let's take a look at the 2024 PA survey findings. I'll start by briefly discussing the impact of PA on physicians who report they complete 39 PAs per physician per week, and this PA workload consumes 13 hours of physician and staff time each week. 40% of physicians also report having staff who work exclusively on PA. According to an advisory issued in May 2022 by the former Surgeon General, burdensome administrative requirements, including prior authorization, are key drivers of health worker burnout. And the AMA survey findings support this assertion, as 89% of physicians report that PA somewhat or significantly increases physician burnout. And unfortunately, it's only getting more challenging and frustrating for physicians to navigate the PA process. 75% of physicians report that PA denials have increased somewhat or significantly in the last 5 years. And nearly 1 in 3 physicians report that their PA requests are often or always denied. Recently, when insurers have heard complaints about the uptick in denials, their advice has generally just been to appeal the denial, which on the surface isn't bad advice, considering that in 2023, approximately 82% of PA denials in the Medicare Advantage program were at least partially overturned on appeal. The problem is only about 1 in 10 PA denials within the MA program are actually appealed. Now, according to our survey data, only 1 in 5 physicians report that they always appeal a denial. So why don't physicians appeal more? 67% report that they do not believe that the appeal will be successful based on past experience, and 55% report that they have insufficient practice staff or resources to do so. I want to highlight this, that 53% report that patient care cannot wait for the health plan to approve the PA. So this third finding is especially problematic because of how challenging and impactful these timing issues can be for individuals suffering from acute medical issues that require prompt care that cannot wait for the insurer to approve the appeal. When time is of the essence and care needs to be delivered as soon as possible, a PA denial can leave the physician and the patient, stuck deciding between an alternative treatment that doesn't require approval or taking a risk waiting for the insurer to approve the PA request before the patient's condition worsens. That's assuming that the PA is even approved at all. So although patients with chronic conditions, may have more time to wait for an insurer to appeal a request before their condition worsens, they still need to receive timely care. Otherwise, they run the risk of turning a well-managed chronic condition into an acute one. Ultimately, no matter how much time is available, the one thing that the PA process guarantees is stress and anxiety for everyone involved in the patient's care, including caregivers, due to the intentionally confusing nature, of the PA process. So the PA process, is especially stressful because it leads to care delays, treatment abandonment, negatively impacts patient care and outcomes, and sometimes even harms patients in severe and irreparable ways. 29% of physicians, or more than 1 in 4, report that PA has led to a serious adverse event for a patient in their care. 23% of physicians report that PA has led to a patient's hospitalization. 18% report that it has led to a life-threatening event or required intervention to prevent permanent impairment or damage. And 8%, or nearly 1 in 10 physicians, report that PA has led to a patient's disability, permanent bodily damage, congenital anomaly/birth defect, or even death, which is a pretty alarming finding. So as I alluded to before, PA also leads to care delays and treatment abandonment. 93% of physicians report that PA at least sometimes delays access to necessary care, and 82% of physicians report that PA can at least sometimes lead to treatment abandonment. PA also interferes with care continuity and negatively impacts clinical outcomes. 89% of physicians report that PA interferes with continuity of care. More than 3 in 5 physicians report that PA at least sometimes destabilizes a patient whose condition was previously stabilized on a specific treatment plan, and 94% report that PA can negatively impact clinical outcomes. And to make matters worse, almost 1 in 3 physicians report that the PA criteria leading to these patient harms are rarely or never evidence-based. On the flip side, when PA restrictions are removed, patient outcomes improve. A study released in 2020 in the Journal of the American Medical Association found that when Medicare Part D plans remove PA for substance use disorder medications, there was a 24% decrease in inpatient admissions, a 28% decrease in SUD-related inpatient admissions, a 36% decrease in emergency department visits, and a 29% decrease in SUD-related emergency department visits. So before I finish discussing the PA survey findings, and I want to highlight the challenges that the frequent changes in benefit coverage and PA requirements, which payers regularly make, can have on patient health. Payers have become masters of shifting what drugs and services they will cover under each patient's specific plan to maximize the insurer's profits. And although it's impossible to predict exactly what changes each payer will make from one plan year to the next, it's really important that patients and caregivers take whatever steps they can to avoid patients winding up in a care continuity gap. Unfortunately, patients and caregivers cannot depend on payers to inform them about coverage changes, that may negatively impact their health ahead of time. So it's really important that patients and caregivers, do whatever they can to monitor payer policy changes to avoid being shocked about a sudden change in coverage. One tragic story that really highlights this was published in the Washington Post in February of this year. A 22-year-old man with severe asthma was previously stabilized on a specific inhaler that cost around $67 for a 3-month supply. When this man went to Walgreens in January 2024 to get a refill, beginning of the year, new plan requirements, he went to Walgreens to refill his preventative asthma inhalers. He was informed that his pharmacy benefit manager, which is OptumRx, a subsidiary of United Health Group, no longer covers his inhaler, and he would need to pay $539 out of pocket to get it. This 8x increase in his out-of-pocket cost was more than he could afford. And unfortunately, without access to a standard preventative inhaler, he suffered a severe asthma attack just a few days later. It left him brain dead, and he eventually passed away after his parents had to make the horrible decision to take him off life support. So while it's impossible to say exactly how this situation could have been avoided, other than just paying the costs, right? It's important to note how often patients learn about these coverage changes, or if a PA is required for medication, at the pharmacy counter, rather than being informed about this change from their insurer well ahead of time. So that situation, the horrible outcomes and just other delays, really highlight how PA increases costs both in the short and long term. Despite insurers continuing to say that that's not the case, right? They argue that these PAs save unnecessary care, they avoid unnecessary spending, but that's really not what our data shows. According to the survey, 73% of physicians reported that PA has led to additional office visits. 47 reported that patients needed to go to the immediate care or an emergency room due to a PA delay, and 33% reported that PA led to unnecessary hospitalizations. 80% also reported that the PA process at least sometimes leads to patients paying out of pocket for medication. So all these data points, from the physician burden to patient harms to the financial drain on our healthcare system, that's why the AMA is really engaged in a multi-targeted effort to reform prior auth. And the AMA is not alone in identifying PA to be a serious issue for our healthcare system. Way back in 2017, we were joined by 16 other organizations representing physicians, hospitals, pharmacists, medical groups, and patients in releasing a set of prior authorization and utilization management reform principles. These principles were built on the underlying assumption that PA will continue to be used for the foreseeable future, and they advocate for sound, common sense reforms to protect timely patient care and reduce burdens. The principles address broad areas of reform, including continuity of care, transparency, administrative efficiency, among some others. So the goal behind releasing the principles was to spur industry-wide conversation regarding PA reform. And in that, we have been successful. Following the release of the principles, we got together with major national provider associations, including the American Hospital Association, the American Pharmacists Association, the Medical Group Management Association, and high-end and insurer trade organizations, including AHIP and Blue Cross Blue Shield Association. We got together to discuss PA, and there was an agreement, consensus agreement amongst all the parties that the process could be and needs to be improved. The outcome of these discussions was the release in January 2018, of the consensus statement on improving the prior authorization process. And this supports 5 big buckets of reform. Selective application of prior authorization through initiatives such as gold carding programs, regular program review and volume adjustment, improved transparency and communication, protections for continuity of patient care, and probably most relevant for this audience, automation to improve transparency and efficiency. While the automation bucket has received a lot of attention, that's why I highlight it for this timely audience. It's got a lot of attention lately as the way to solve PA burdens. And I want to emphasize that the AMA believes there's more than just automation that'll solve this problem. We need a multifaceted, holistic approach to PA reform that incorporates but does not solely rely on automation. Many of the changes our healthcare system needs to make with regards to PA require payer policy changes, not just modifying the process. For example, are the underlying clinical criteria that insurers use when making PA decisions current and valid? Our survey findings say no. Only a third of doctors say they are. Are insurers, do they have the appropriate protections in place so care isn't disrupted when patients switch plans? Or just changes are made within the same plan. Really, at the end of the day, I can't stress enough how critical it is that we as an industry recognize that even the most advanced tech solutions will never be enough to fix our significant PA problem if some of the parties involved, namely insurers, refuse to do their part to reduce PA burdens. $1 million question, which you may be able to guess the answer to, is of course what happened following the consensus statement released in 2018. Payers honored their commitments and the PA process was fixed, right? Unfortunately, no. I'm sorry to say that despite 7 years having passed, we've seen more payer stagnation than progress. As you can see from the AMA survey data we have listed on this slide, physicians are still reporting significant challenges with the issues addressed in the consensus statement. Overwhelming majority of physicians report that the volume of drug and medical services PAs have increased in the last 5 years. Gold carding programs are few and far between. Most physicians still encounter challenges, even determining if a drug or service requires PA. Physicians still see the process interfering with patient continuity of care at an alarming rate. And less than 1/4 of physicians report that their EHR system offers electronic prior auth for prescription medications. And this is just always shocking to me. Every year we do the survey, we ask about methods of completing PAs, and phone continues to be the most often used method to complete a PA. And just endless frustration channel there. So next, I'm gonna finish up by going over some give a quick update on some recent legislation and regulations that have been passed at the state and federal level to mitigate PA burdens. So first, very pleased to share that many states who we work closely with to try to get PA reform done on a state level, they're aware of the negative impact that PA is having on patients and physicians. And as a result, there's been a lot of legislative activity at the state level surrounding reducing PA burdens. Since 2023, more than 24 state laws have been enacted that address PA denials, the appeals process, and PA burdens more generally. I kind of provided a couple examples here on the list, but I think the big thing to take away is, as I discussed earlier, the states have recognized that it's a multifaceted, many-angle approach towards fixing prior auth. Obviously, we have different types of automation requirements and different processes improvements that'll help get us there. It's ultimately a web and a fabric of different changes and policy shifts that we need to have in order to make PA burdens to reduce PA burdens. So at the federal level, legislators and regulators have also begun to acknowledge the extent of the PA problem. Multiple major reforms specifically addressing PA burdens have been finalized in the last few years, and there are more reforms being considered. For instance, the Center for Medicare and Medicaid Services, or CMS, has recently released multiple final rules that are designed to reduce PA burdens for Medicare Advantage and Part D beneficiaries and physicians. However, while these rules and regulations are promising, I again want to emphasize the commitment that will require on the health insurer's part to actually improve the PA process. The insurers are incentivized to make the PA process clunky and disruptive. The most effective way to save money, after all, is to avoid delivering care. And that is exactly what the PA process is designed to accomplish. So unless insurers change their philosophy behind why they require PA in the first place, it's going to be challenging to reduce PA burdens significantly or even slightly. One thing I want to mention, sort of a recent development, that on June 23rd of this year, a group of major insurers, including United Healthcare, CVS, Aetna, and Cigna, among a bunch of others, announced voluntary commitments to streamline and improve the PA process. While the AMA supports any voluntary commitments from the payer community to reduce PA burdens, we have reservations about this promise. And, we felt a little bit of deja vu when we heard the announcement, because it's like, haven't we seen this before with the consensus statement? I thought we already did this. If you take a look at the payer announcement, the details of it, you can see that a lot of the changes they're proposing and the buckets are kind of the same as the stuff that was provided back in the consensus statement. They're modified a little bit, but in general, a lot of the changes they're saying they're going to voluntarily do are pretty much what they agreed to do back in the day. So we asked ourselves, how's this going to be different but from before? Is this just another instance of payers sensing that regulation is coming and they're going to try to get ahead of it with some, good press and voluntary action? Ultimately, only time will tell. And again, we're trying to maintain a glass half full perspective on this, but we just know that payers need to stand by these new commitments and really invest financially, just with personnel and the resources into making the PA process more efficient and less disruptive to care. So I'm going to finish up just a couple more things here. I just want to highlight some of the AMA's PA advocacy resources. Back in 2018, we launched our grassroots website, fixpriorauth.org. And for those of you who are not familiar, this is really a great platform for people to stay engaged on the latest information about PA and really tap into our many different PA resources. As an educational hub, we house most of our resources on fixpriorauth.org, including our PA model build, which states regularly use to write their own PA legislation. And we also populate the website with the latest news stories and anything else relevant to our efforts. And one other big thing that we do on the website is we collect patient stories and which is a very key tool in the advocacy arsenal because we have the data on one side and then you have to bring it down to the more granular individual level to really bring about change, right? So we recognize that we needed a place to collect the stories. And over the past 6 years, we've collected over 1,300 patient, physician, and provider stories. Some of them are really extremely disheartening. There's a couple of examples on the page here, but I think it's really just, big picture. A lot of the stories that we hear and we share really highlight common misconceptions that many people have about PA. I think the one in the middle, especially about Celebrex and generic Celebrex, it's like a lot of people assume that PA is not required for generics. If it's cheap, probably no PA, and that's becoming less and less true. We see $8 generic requiring prior authorization. It's like a lot of times patients will be stabilized on this medication for years, and then all of a sudden, some type of cost saving effort puts prior auth in this inexpensive medication, and all it does is disrupt care, possibly lead to really expensive hospitalizations or other treatment requirements, and it can really be counter effective. So please explore the website. The Pix Prior Auth for a lot of stuff, a lot of good stories that I really don't have time to get into. But I think on there you'll really get a sense of exactly why we need PA reform, and including clinical validity changes, volume reduction, transparency improvements, all working alongside improvements in the automation of prior auth. That's it for me. My contact info on there if anyone wants to reach out to me. Talk about anything prior auth. I do a lot of pharmacy regulation work as well. So I have many other things to talk about, but this is one of my areas of focus. So thank you for having me.
Thank you, Tyler, for providing a comprehensive overview of prior authorization and the impact it has on patient care. To delve deeper into navigating the healthcare system, I'm pleased to introduce Dr. Douglas Constant, pain management physician based in Florida. Dr. Constant, I have to thank you for really offering your insights today because caregiving is such a all-encompassing role that caregivers really lean into. And as a physician, you really provide a unique perspective and experience when it comes to caregivers and patients and care coordination. They all are intertwined, and so I'd be curious to ask you, what do you see as one of the greatest challenges that families and patients, navigate, and how can they be better equipped themselves to be able to successfully navigate those challenges?
Marvell, thanks for allowing me to address that, and thanks for letting me be part of the panel with you today. So, as a physician here, and I'm in Florida, part of an orthopedic group, we deal with patients from a variety of backgrounds and a variety of ages. But to specifically address that question, I think understanding from a caregiver when you're responsible for another individual's care, what are those benefits that they're receiving? Also trying to navigate the billing aspect. And I know those are not necessarily exciting topics, but they're very germane to the challenges because sometimes
Yes.
the way those bills are written, it's almost as if they're purposely obfuscating and making it challenging to navigate. And I don't mean to sound pernicious, but it's anything but straightforward. And even the most educated individual struggles, I think, to sometimes understand what's an EOB versus what's the actual due charge. And that's a hard thing. And sometimes working with a clinic manager from that facility can help deconflict and demystify some of those misunderstandings. But even beyond that, as I think that you are aware, and anybody who's participated in healthcare in the United States as a recipient of that healthcare, we unfortunately have a very fragmented healthcare system. And instead
Mhm.
of having a wheel with spokes that go outward that allow clear and concise communication back and forth, you're left kind of bereft with one island not communicating to another island about the care. And I don't mean to sound complicated, but it's still frustrating that I endeavor every day with my patients to communicate my clinical notes, my operative notes, et cetera, with the primary care physician, and if there's a germane or relevant specialist. That is not reciprocated in kind almost all the time.
Mm.
And that is a huge challenge. And so as a caregiver, having a list, and it sounds simple, but it's so important of, hey, which doctors is my mom, my husband, my spouse seeing? What is their full name and correct spelling? What is their facsimile number? What is their address? And even if there's an email for a clinic manager, that's helpful. And if you can share that and then be kind and courteous, but respectfully and forcefully say, hey, I would like you to share the clinic notes, the medications, all this with these other doctors, because ultimately it is amazing that we encounter on a daily basis patients that are unsure of their own diagnoses, their own treatment, and that's no fault of their own because sometimes this is complicated language and complicated
Mhm.
circumstances. But the people charged with that responsibility of caring for them should, in the background, be coordinating. And instead, there's no real accountability other than people doing the right thing to do the right thing.
That's perfectly put because it really underscores just that the caregiver being that bridge and caregivers, having willingness to lean into that, but needing the guidance like you just gave them, like how do I effectively do that? I want to be a good advocate for my loved one, for my mom, for my dad, my sister, my brother, anyone else. They want to be great advocates for it, but they also don't understand what happens behind the scenes, and the fact that their ability to give that information directly to the provider, so they can contact the other provider, know that it's important to really make that connection, is a great realization for caregivers to have, because sometimes you put yourself in a position of thinking that you aren't as important to this as you really are, and so understanding just how much that bridge can be effective for care and communication, especially between providers. So, switching gears a little bit, when we sent out a poll prior to this webinar, and respondents found that prior authorization to be really one of the most, if not the most challenging part of navigating care. So what steps can patients take to better advocate for themselves during this process, and through that, what steps can caregivers take in order to support them?
So that's a very thorny issue that
Mm.
I think everybody agrees it's difficult and onerous and frustrating. And insurance companies, in their endeavor to contain costs, have now created a system that I think adversely affects patient care and patient flow through a treatment plan. So there's something called a medical policy statement, and that's a very dry term. I know that.
Mm.
But if you Google medical policy statement for Blue Cross Blue Shield Michigan or Aetna California, you will therefore from the web glean a document that will explain for a specific treatment or study what needs to be accomplished for that to be successfully authorized. I say that only because patients are at a disadvantage, as are their caregivers, because they don't have the playbook. The insurance companies have the playbook. And the even more frustrating thing is this thing called site of service. And unless you're playing within this field of sport that we're discussing, you and myself, you have no idea even what some of these terms mean. But site of service meaning, hey, is mom going to get her hip done at an ambulatory surgery center as an outpatient?
Mm-hmm.
Is she going to have that done inpatient in a hospital? But this medical policy statement is supposed to clearly delineate the steps of how do we get this successfully authorized. And sometimes that can be very helpful in particular because, as you know, there are many different insurance companies, and even within a particular state, there may be varieties within Florida Blue, different types of Florida Blue. And so when a physician or the physician extender orders a particular treatment or a study like an MRI and it gets denied, understandably a patient is upset and they get frustrated, but it's not always the doctor or the nurse practitioner's fault because you've got this
Mm-hmm.
artificial authorization process. And if a patient or their advocate, the caregiver can review or at least be cognizant of what this medical policy statement says, then oftentimes that empowers them to at least present to the doctor's office with some of that information readily available. And let me bring this very esoteric discussion to kind of a concrete example. And that is just a simple like lumbar MRI, an MRI of your low back. There are a
Mm-hmm.
lot of points of friction in trying to get that authorized when it should be a straightforward thing. And one of those points of friction is what's termed conservative care or conservative treatment. Well, what does that mean? These medical policy statements delineate, oh, well, that means you had to have had some physical therapy within 3 months prior to this doctor's visit. And if you failed that, then now we'll authorize your MRI. Well, if a patient knows that that's part of this process, then they can readily, hopefully, determine, hey, where
Mm-hmm.
to have that PT done, volunteer that to the doctor. What were those dates? Was it helpful, not helpful? Or in the event that it's painful and they can't
Mm-hmm.
participate, they can volunteer that. And that aids that whole authorization process instead of this tennis match volleying the ball back across a net for which we're not moving forward to the objective of
Right.
getting the darn MRI approved and through a treatment plan. That sounds simple, but the other thing is sometimes literally writing your local congressman. And I know that seems like a very
Mm-hmm.
um, large effort, but really, it's interesting that when you use the term the squeaky wheel, gets the grease.
Mm-hmm.
And I have found that it sometimes just working with a medical director at an insurance company is not as effective as sometimes engaging with your congressional support.
Dr. Constance, that makes so much sense because we talk about, from Caregiver Action Network's platform, we really try to empower caregivers to be proactive in whenever they can, because it's also, many times you're a caregiver and you feel like you're just reacting. Something happened, you're reacting to that. This comes up, you're reacting to that. And when you talk about, really being able to understand, the ways in which you may need to engage with that provider, understanding what the insurance company will be looking for, understanding, like you mentioned about the having the therapy before considering another treatment. That allows the caregiver to give them the energy to be proactive and understanding, like, okay, I can get ready for this next stage instead of, kind of being in the back seat of this. And so that makes perfect sense. Just a pivot to talking about your specialty. As a pain management physician, you've obviously navigated the evolving, pain treatments in the healthcare landscape. I found as I get older, pain becomes something that I need to be able to be aware of and navigate on a regular basis. But again, just curious of how do you ensure that those that are under your care have access to, innovations in pain treatment options, and understanding what that landscape looks like, and what barriers do patients face in trying to access, those types of pain treatments?
So that's a multi-pronged question. To address the first part of that, I stay current in the field, obviously, with not only continuing medical education, but as we develop new therapies, trained on those therapies, and I still teach in academics. So my job is to present choices to patients, and then I try and support them with what best fits their current needs and their projected medical uh, care plan of care in context of their entire health. However, what do I do to ensure patients have access to this, I actually speak to the US Senate and speak to the US House. I'm one of 25 physicians that discuss healthcare with the US House and US Senate. And I advocate for them. And we've been successful with surprise billing to improve that, been successful in repealing certain prior authorization mandates.
That was extremely helpful. I mean, it gives you really the respectfully, the complexity that's involved with that really required you to really walk us through it. And thank you for really touching on these points so succinctly, because it for the takeaway I'm hearing is, as we say to caregivers many times, that use your voice. And so whether it's from caregivers making sure that they come to the doctor's office and they are advocating for that connection between one provider to the specialist and being able to be that bridge, whether it's as you mentioned about reaching out to your elected officials, and also making sure about what the prior authorization process may be and what they may be able to do proactively. All of that is allowing that caregiver on behalf of the patient to really use their voice and advocate and really get out ahead of some of this stuff, because as you mentioned, some of it's out of their control, which is very frustrating, and kind of leaves them helpless at times. But there are things they do have control over. So, Dr. Constance, thank you so much for taking the time today to talk with us. This has been really informational and helpful, and I'm quite certain that the caregivers and care recipients that are participating in this will really appreciate the information you've shared. So, thanks so much.
Thank you.
Wow, this has been a really impactful and informational conversation today. My sincere thanks to all the participants who joined us. There's a road ahead to navigating the healthcare system, but together we can advocate for change and make a lasting impact. Be sure to check out the Families, Addiction, and Mental Health Network website to learn more and access supportive resources, including a caregiver discussion guide and a care coordination fact sheet that outlines all the key stakeholders in the care continuum. Thank you to everyone for participating today, and we hope to see you again soon.